Okay, yes. So, hi, I'm Kristine. I'm a PhD student in Denmark, and I'm a psychologist with a specialist degree in psychiatry. My PhD is sort of divided between, well, the place where I'm employed, which is Regions Zealand Psychiatry East, an adult psychiatric center in Denmark, and I'm enrolled at the University of Southern Denmark. And a little about me, I'm married, I have 3 children, a cat who's with me here, so he might pop up. I'm trying to keep him away, but it might happen. And I have a lot of plants, it's just my hobby. So a little about me. Okay, so I was employed last year, 1st November, which was, then I was supposed to do the protocol for the PhD. But because of, and I've realized this is part of the PhD life, when we tried doing the protocol and contacting the university, they had this sort of a special clause that you had to have published something before I could become accepted, but I hadn't published something. So then we had to work around that, and I just had to sort of stay employed at Regions Zealand Psychiatry for half a year before I could get my protocol accepted. So that's why when Lena says that I'm actually sort of, even though I've just been enrolled in June, I'm actually really ahead of my project because I just sort of started working for a year now. So I don't have any results yet, but I do feel like I have good time. My sort of the frame is I have 3 years to complete the PhD. I'm supposed to write 3 articles, and I'm luckily fully funded by Region Zealand Psychiatry. A lot of other PhD fellows in Denmark, it depends sort of what your employment is, but some have to find funding, but I'm quite fortunate that I have full funding. Yes, so this is my project. The impact of staff education and training on managing non-suicidal self-injury, and I'm looking at staff attitudes, work-related injuries, and coercion. And we're looking in it's an adult psychiatry, even though I mean self-injury is well, it spikes around youth, but we do have a lot of adult patients who have really severe problems with self-injury, and it is quite a major problem in the psychiatric settings. And my focus is actually on the staff, but I'll tell you more about that in my slideshow. And these are my supervisors, Miki Kongerslev and Erik Simonsen and Carsten Hjortrød. Yes. Okay, so just to define what is this non-suicidal self-injury. I'm not sure all of you are familiar with it, but the definition is, we'll sort of divide it into being direct self-injury, self-harm, and indirect. So the direct self-injury is defined, it has to sort of have, you have an intentional destruction of your own body tissue, and it can be any kind of body tissue, because some people, they self-harm by swallowing things. It could be internal tissue or external tissue. And we distinguish it from suicide by the intent behind. I mean, so if we're talking about, the focus I'm having here is self-injury is defined and separated from suicide attempts, is there is not a suicidal ideation behind. And also you have to look at the intentional destruction of your own tissue. It has to be not socially sanctioned or culturally accepted. And that's because if you might have incidents in some cultures. I know there's I can't remember what country in Africa, but there is sort of a country with a local tribe, and they have sort of a rite of passage ritual for young men, boys becoming men, where they actually put on these like gloves filled with fire ants, and they bite their tissue, and it's very painful. But that's culturally acceptable and a part of a ritual, so you can't define that as this non-suicidal self-injury. But that's just very technical, but it's a way to sort of in all the literature to sort of define what you're talking about. And then if we look at the indirect self-injury, you can put everything in this category. It can be substance abuse, eating disorders, what am I looking for? Well, just anything really. A lot of it sort of, but here we're talking about things that sort of have a it will harm yourself, but over time. And it's, of course, it varies in type and severity. We have for example, there's a type of non-suicidal self-injury where it's called as self-harm by proxy. It's actually where you don't perform the harm yourself. You get other people to harm you, and that's relevant in a psychiatric setting because we do have coercion. Where you because of your mental illness, we have to sort of intervene and use coercive measures. It might be restraint, or it might be medication. And what we do see, what the literature tells us, is if you sort of block a person from being able to performing direct self-harm, the situations tend to escalate, and then they tend to sort of seek the same release by getting other people to harm them. And that might be a situation we see all the time in a psychiatric setting. It could also be maybe for gang members who sort of seek out other gang members, or and sort of have arranged fights. There might be an element of seeking this self-harm by seeking out, fights. But what we see with this this behavior is that once it starts, it usually starts when people are, adolescent, around 17 years old, and it just escalates over time. It gets more and more severe. The cuts get deeper and deeper, and it gets more frequent. And it has a strong association with suicide. So it's quite important that we look at this problem and take it serious. Because a lot of people who have a history of self-harm also tend to have suicide attempts. Okay, and the reason why I'm sort of focusing on staff is because of this sort of escalation of the behavior, we do see that non-suicidal self-injury is associated with the great frustration among staff in the psychiatric settings. Also, well, but just generally people who have to care for people who self-harm. There's a lot of negative attitudes, negative emotions concerning this behavior because people feel overwhelmed. Just like Ivana talked about burnout, actually there's this association with burnout when you work with people who self-harm, and this concept of a brutalization culture, because you have these the feeling is I'm set in this world to help this person with her problems, and I can't help her, and she keeps on harming herself, and I keep on trying to help her not do it, and she just keeps on doing it, and then over time it burns out people. And so we do see a lot of problems with understanding why do people keep self-harm, and that's why well, I find a study, I didn't put the reference on, but the negative attitudes around and concerning non-suicidal self-injury is actually only surpassed by patients with substance abuse problems. So it is a category of patients who really are misunderstood and often not treated optimal, because the people who are supposed to treat them, they don't have the right skills. They feel like it's not helping what they're doing. And then I looked at studies that have shown that, well, if you then educate and train these people who are supposed to care for people who self-harm, then you can see an improvement of attitude, an improvement of, from negative feelings to more positive feelings. But there wasn't really a lot of studies that showed how does this translate into actual outcomes. And my own personal reason for going into this project is that I have been working as a clinical psychology in adult psychiatry for 10 years. And I started out in a DBT therapy team, dialectical behavior therapy. I don't know if you're all familiar with that, but it's a therapeutic treatment, and it's actually developed for people who really self-harm, have a lot of suicide attempts, and so that's where I started. But in Denmark, at least, to get into a DBT program as a patient, you have to sort of, it's an outpatient program. It's not, there isn't really anything for inpatients. So if you're, and that's where I started getting more specialized in treating or just working with people who had really severe problems with suicide and self-harm, that they were excluded from outpatient treatments. As it says here, they were often way too unstable to attend these treatments. And then I saw this problem, well, there's a discrepancy here, because the most complex patients with the most severe problems with self-harm, they tend to circulate in inpatient units because they get submitted all the time, admitted, and that's where you find the sort of least educated or trained staff in inpatient units. When you're talking about knowledge about what is this self-harm and how to help these people, because there isn't a sort of a whole treatment team. It's when you're in an inpatient unit, it's sort of, well, you're in here for a short time, just to we have to take care of you and out again. So that's what I found, and I found it very frustrating. And I found what all the literature says. I found all these frustrated staff who really didn't know what to do, but they kept on having this really big assignment, help these people. So what I wanted to do, and my aims with my project, is to implement education and training to all staff from the inpatient units in Region Zealand Psychiatry in the East. Well, and that's because Region Zealand Psychiatry is sort of divided into 3 major hospitals. There's East, South, and West, and I'm employed in East. And my outcomes is what I hope this education and training will translate into is that, can we see a reduction of the number of coercive measures and work-related injuries? Because when you do have coercive measures, you do have work-related injuries, because staff hurt themselves, because these situations can get quite severe. And what I wanted to sort of look at is, can this staff attitude can that be a mediating factor if we so what I'm looking at is can we sort of see a rise in attitude from negative to positive, and a sort of decline in work-related injuries and coercive measures? And the method I'm using is it's a mixed method study, a quasi-experimental naturalistic study, and sort of divided into these 3 sub-studies. So the first sort of study is this naturalistic study, where I'm doing an interrupted time series design, because we have all these different units. I think there's 6 units, and they have all, well, I have implemented it already. They've all been through the first part of the education and training. And here's a fun thing that happens when you sort of have an idea of a research project that meets reality. Because what I wanted initially was to maybe give them like 5 days of intense training and education. But then, reality hits, and we have this hospital that just has to keep going, and it has everyday patients you have to care for. And it wasn't possible to pull out all the staff for that long. So we got 1 day that I could sort of go through the basics. But what helps my project a lot is that Region Zealand Psychiatry has sort of just before I was employed, decided to form like a regional strategy to sort of say, this is how we'd like to treat people who self-harm. And it had just sort of begun to roll before I was employed. So I'm sort of part of the hospital's own program to actually educate and train people. But I've been the one who's been allowed to design the education for the East part. And yeah, so that's the sort of the big study that I'm looking at. Then there's also a psychometric study, because how I want to track attitudes is I found this questionnaire, self-harm antipathy scale questionnaire, and I translated it into Danish. And then I gave all staff had this questionnaire before the training and education, before the education day. So I had like a baseline, what are your attitudes now? And this questionnaire, it's as it says here, it sort of measures antipathy against people who self-harm. It also measures the feeling of competence. Do I feel competent? Do I really know how to help these patients? So that's actually, I'm working on that now. The first article is looking at, does my translation work? Does it actually ask what I say I'm asking? And we're looking at that now. And then I gave them, they've also had the 2-month follow-up. They've had that questionnaire also. So now I need to do the 8-month follow-up, which is going to be in the beginning of next year, I think. And the third study is a qualitative study, where I'd like to go deeper into this attitude and this sort of the staff's sort of, well, what do they think of this whole thing, the whole shift in thinking? Because the way they were taught to think about self-harm before the strategy and before the education was, well, we have to stop people who self-harm. You have to stop them. We have to stop them at whatever cost. And this new strategy says, well, we have to help them to help themselves stop. So it's a different way to work. So the study, I'm going to do a focus group interview also in the new year, where I'm going to ask all the people who participated in the education and training day, sort of what do they feel? Did they feel more confident? And maybe I haven't done the questions yet, but I think I'm very inspired by the questionnaire. There's a lot of those questions, well, actually statements that I'd like to dig deeper into and maybe get some more qualitative data on what actually lies behind the way they answered. So those are the sort of the 3 things in my big study. And this is just a way to show you what it looks like. So this is sort of a timeline. You see, these are the units, 1, 2, 3, 4, 5, and this is PAM. That's the sort of the emergency. I don't know what it's called in English. Well, the emergency units. The first place you go to, and this indicates just raw data that we already have. What actually in 2021? How many coercive measures? How many work-related injuries were there connected to self-injury? And we are also tracking in 2022. And then I came here around May. I trained them. I had my day. And that's where we were, of course, also looking at this data. It's just there all the time in our system. But that's when they got the first questionnaire. And this is the 2-month follow-up. They've got the second one, and I'm still looking at the data. I haven't done anything with it yet. I haven't analyzed. And this is for the future to come. They're going to get the questionnaire one more time. And actually this brush up here, brush up of education, I've actually moved that a bit forward. They've already sort of had a brush up here. Again, because of reality and because of the way a hospital works, it made more sense to do it here, because there was already a lot of days the staff were going on another type of training course, and I was allowed to sort of buy myself 2 hours of their time, so they've already had the brush up. So the design has changed a little bit. Yeah, so this is what it looks like over time. And these are just the research questions, just penciled out. Will this education and training, will it actually reduce, can we say that it actually reduces the amount of coercive measures related to self-harm? We do have some raw data now just in the system we normally use to track coercive measures. And I've been told that since the strategy was implemented, well, before my time and before they started doing all these part of it, we do see a reduction in coercive measures. And then the second one, again, is part of my aim is, well, I said, well, that's very fine. I mean, but just because we have a reduction in coercive measures, it could just mean that staff have they were literally said, well, now we're not going to touch people who self-harm. So that will, of course, give a reduction in coercive measures, because before we would go in and sort of force them to stop, and that's why it would tick out in being, something we could track. But we would like to see, well, what that's just not enough. We have to look further behind that, because a lot of staff have sort of said that what they find difficult now is, well, then I have to watch someone self-harm, and then we can see a rise in work-related injuries. Well, that's sort of mental ones, because it's very difficult to watch someone self-harm if I'm not supposed to intervene. And that's what I'm helping them sort of figure out. Well, you have to figure out, you can't just not intervene as a rule. You have to know the different types of self-harm. There's especially the severe type where it's quite dangerous what they're doing, then you have to intervene. Or if it is sort of tips over and becomes a suicide attempt, you have to sort of know this. And that's part of the training and education program I gave them. And then again, the mediating factor, really looking at what I'm hoping this questionnaire, can it track sort of a change of attitude over time? So all the participating staff, they've sort of had I gave them a trial number. So maybe some nurse, she attended the first, the big education day, and I gave her trial number A1. And at follow-up, I gave A1, here's your number 2 questionnaire, and here's number 3 questionnaire. And maybe I can see an individual sort of switch. Maybe A1 started out thinking, well, I have lots of antipathy towards people who self-harm, and maybe at 8 months, it's sort of, well, now I have lower antipathy because I understand them better. But I'm not sure. When we'll see if the questionnaire can do that, because that's not how it's been used before. It's just been used as a sort of baseline. What are people's attitudes? I don't think, well, I haven't actually found any studies that try to sort of track attitudes over time. Yeah, so I think that is it. Yeah, pretty much.